Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are moving on from the thorax and down into the abdomen, and the first thing we're going to talk about is the liver, the anatomy of the liver. The Couinaud classification divides the liver into 8 functionally independent segments. Each segment has its own portal triad, that's artery, vein, and bile duct, making segmental resection possible. This segmentation is widely used in surgery, in interventional radiology, and imaging reporting. Now, the segments are numbered clockwise, starting at the caudate lobe, which is segment 1. And then you now move to 2, 3, 4, 5, 6, 7, 8. You've noticed you're just counting in the clockwise direction. And segment 1 is posterior. That's why we are not seeing it as we are looking at the front of the liver. The remaining segments form a circle as we're looking at it in front. So you can see 2, 3, 4, 5, 6, 7, 8, like that. And this visual helps orient us whether we are looking at a CT, an MR, or even surgical anatomy. Now, it's important to remember that segments 6 and 7 are posterior and they are not really visible on the frontal view, but this is just a schematic to let us see how the counting goes. Each segment is supplied by a central portal triad, as we stated earlier, and then it drains via peripheral hepatic veins into the inferior vena cava. So you can see that these are the hepatic veins. Of course, it has multiple tributaries that are serving the various segments, which are peripheral, and then eventually will all drain into the hepatic veins and then into the IVC. This dual system explains why liver diseases can affect inflow and can also affect outflow separately. Think portal hypertension in the case of inflow problems, and Budd-Chiari syndrome in the case of outflow problems. So to recall the segmental layout, here's a mnemonic. If we take a superior slice, the segments you are expected to see from left to right are 2, 4, 8, 7, and then 1 is at the back, right? And then inferiorly, we are going to see 3, 4, 5, 6. And you can remember the superior segments by just doubling each number. So starting from 2 doubles to 4, 4 doubles to 8, and then 8 minus 7 is 1. So you have 7 and 1. 2, 4, 8, 7 and 1, right? And then for the inferior one, it's much simpler. Just start counting from 3. 3, 4, 5, 6, right? By the lobe, the left lobe is what is on this side. So segments 3, 2, and 4 are in the left lobe, and segments 5, 6, 7, and 8 are in the right lobe. The caudate lobe, which is the segment 1, stands alone because of its unique drainage and functional independence. It stands alone. It's not considered as either left lobe or right lobe. The portal vein, which is this one, bifurcates into right and left branches, which further divide to serve each segment. The anatomy is key for radiologists when assessing segmental perfusion and also for surgeons during transplant or resection planning. The hepatic veins, that's the right, the middle, and then the left hepatic veins run in between the segments and drain directly into the inferior vena cava, which we have already stated. And this makes them great landmarks on axial imaging when you are trying to identify the segmental borders. There's a little controversy regarding the left hepatic vein, however, whether it is actually the landmark dividing segments 2 and 4, or it is the falciform ligament that does the division. Well, in real life, when you find a lesion in either segment 2 or segment 3, most of the time it is a lateral hepatectomy that is done. So both segment 2 and 3 are taken out anyway. So don't worry your head too much about the nitty-gritties. Most of the time, the hepatic vein, the left hepatic vein, is a little lateral to the falciform ligament, and so you may end up reducing the size of the lateral segments and increasing the size of segment 4 if you use the left hepatic vein, or if you decide to use the falciform ligaments, you end up maybe reducing the size of the segments 4 and increasing the size of the lateral segments. But the consensus is moving a little towards using the falciform ligaments, fissure as the landmark for dividing the left lobe into 2, 3, and 4. As I stated earlier, the caudate lobe is special. That's the segment 1. It drains directly into the IVC and not through the hepatic veins. So it's often spared in bad Chiari. I mean, we'll come to know what bad Chiari is. And also in liver cirrhosis. It may hypertrophy to compensate, helping maintain liver function in those conditions. So this image shows hypertrophy of the caudate lobe in a patient with liver cirrhosis. You can notice that the right lobe is small and lobulated. You can see the contours are lobulated. It's shrinking compared to the left lobe. Then there's also what we call the papillary process of the caudate lobe. That's a small part of the caudate lobe, and it projects medially and can look like a mass or lymph node on a CT. This is a normal variant. It's not a pathology, and knowing this would help avoid misdiagnosis. So you can see here in the region of the caudate lobe, there is this tongue-like liver tissue that is projecting from the caudate lobe and extending medially. This is the papillary process of the caudate lobe of the liver. So just to give us a bird's eye view of what we have discussed today, when you are scrolling through your CT, you are just trying to visualize these imaginary lines that are created by the right hepatic vein, the middle hepatic vein, the left hepatic vein, the falciform ligament, and using these lines to segment the liver. We know that the portal vein is what is dividing it into superior and inferior, but then you will not always be seeing the portal vein on all the slices. So some of the clues that would tell you that, oh, I'm looking at a higher slice, and so the segments I am looking at should probably segment 2, 4, 8, and 7 would be, perhaps if you see the lungs in view, you'll be thinking, oh, I'm at a higher slice. If you start seeing the porta hepatis, or you see the pancreas or the kidneys in view, then you think that, okay, you're at a lower slice, and as such, you should be seeing segments 3, segments 5, segment 6, because they are the lower slices. So just a bird's eye view of what we have discussed so far. The next thing we'll talk about is imaging of the liver. So the imaging modalities that we use to evaluate the liver. Thank you very much for your attention. If you've got value from this, give it a like, share, subscribe if you've not subscribed yet, and I will see you in the next one.